Good evening, faculty members and our delegates. I welcome Dr. Pragna Patel on the behalf of INTA's Zenith Division. Welcome you on the 28th episode of Endocrine Talk Show. As we all know, many of the women have early menopause right now in today's era because of many factors, and also the life expectancy of the women are increasing year by year. So many of the women has to spend many years in a menopause. So that is the current challenge ki how to manage postmenopausal symptoms. So with this we are coming with our new series on hormone replacement therapy, on what are the current status, what are the dilemmas and other thing. And to introduce to our topic, we have our prestigious group of faculties, and I will take the honor to introduce one of the respected faculty member, that is Dr. Professor Subhankar Chaudhary. He has done MD, DM in endocrinology, DTM, and MRCP. He is currently working as a director, Department of Diabetes and Endocrinology, Medica Hospital, Kolkata. He is also worked as former head Department of Endocrinology for SSKM Hospital, Kolkata. He is a member of Subject Expert Committee Endocrinology for CDSCO, Government of India, and it is one of the prestigious work he is doing right now. Also, he has published more than 230 publications on various national and international journals. And he is honoring us today with the chairperson or maybe moderator of our today's talk. So with this, I will hand over the session to Dr. Subhankar Chaudhary, and he will guide us from here further.
Thank
Dr.
you. Thank you
Yes.
very much, Dr. Pragna. It's wonderful being part of this program over the last several years now. It's the 28th episode this evening, and we've been talking of different areas of endocrinology which we feel would be of interest to the practicing physician. I hope we are able to cater to their needs over the months and years. So, this evening we shall talk about hormone replacement therapy, and here we refer to post-menopausal hormone replacement therapy, not hormone replacement for thyroid deficiency or adrenocortical deficiency. And to take us through, we have a galaxy of speakers, faculty from all across the country. We have a guest faculty in Dr. Shukanto Mishra, who is professor and head at the Vivekananda Institute of Medical Sciences, of course, in obstetrics and gynecology. And he has been a very senior person in the field, has had various publications, is also member of the PhD committee of West Bengal University of Health Sciences since 2012. We also have this evening with us a host of endocrinologists. We have Dr. Ganpati Bantwal, who is professor in the department. Can we change the slide as well? Would someone? Yes, thank you. Who is professor department of endocrinology at St. John's Medical College in Bangalore, and he was a past president of the Endocrine Society of India, and he's been recipient of so many different awards and orations. Welcome, Dr. Ganpati Bantwal. We have with us this evening a very talented, enthusiastic endocrinologist in Dr. Deep Datta, who is practicing as an endocrinologist in the Cedar Super Specialty Healthcare in Delhi, formerly assistant professor of endocrinology and member of ethics committee at the Dr. RML Hospital, Delhi. And now comes the important bit. He has already had 235 publications in indexed journals. That's a great achievement. And he's also, of course, currently Joint Secretary of the Endocrine Society of India. We have with us this evening Dr. Arundhati Dasgupta, who is Director and Consultant Endocrinologist at Rudraksh Super Specialty Care in Siliguri. She has received various awards for her recognizing her talents, and she is an excellent speaker and is a regular speaker at various national and international fora. We have with us, of course, also Dr. Girish Parmar, who is consultant endocrinologist at Nanavati Super Specialty Hospital, Mumbai, and he's treasurer of the Maharashtra Endocrine Society, a founder member of Ascent Group of Endocrinologists in Maharashtra. So, with these excellent sort of talent pool with us, let's try and get into the subject of hormone replacement therapy. And as we said, we talk about menopause only. So, my first sort of question is to Dr. Sukanto Mishra, our guest faculty this evening. Why is it that women have a definite sort of termination of the reproductive period, while for men it is not such a distinct, a discernible event? So, does menopause serve any useful purpose in women? Why did nature place menopause?
Uh, Thank you, Dr. Shubhankar Chaudhary. And at the onset, I'd like to thank you, just and of course the entire panel of brilliant endocrinologists across the country. When it comes to menopause, the similar term andropause, I believe, is also there. It basically, menopause occurs in ladies because of the finite number of latent follicles which continues to secrete estrogen during the reproductive phase. Unfortunately, menopause has a negative connotation in the psyche of the ladies, but it certainly has certain useful advantages, like the women do not have any periods. That means she is free from all sorts of problems related to periods. She doesn't have to bother about it, particularly about the unpredictable bleeding when she is out of her home. Because she is not having periods, she doesn't have any cycle-related problem like cyclical nostalgia, mood swings, sense of bloating, menstrual migraine, and so on and so on. Because she is not having period, the blood loss will be minimized to a large extent, and her anemia will improve. She will feel much better. Because she is not having period, she does not require any contraceptive either. It's unlikely for her to conceive at menopause. It's not impossible. The contraceptive and the inherent disadvantages of the contraceptive. Then, of course, it protects the lady from reproductive morbidity and mortality, which is extremely important. It also gives relief to the lady regarding some estrogen-related diseases. Diseases, I mean, like fibroids, endometriosis, some of the symptoms, reduction in the sizes of endometriosis, so on and so on. And finally, I believe it gives freedom to the lady want to go on this, so they can put more emphasis.
Menopause to us as something very positive. So, should we at all bother to treat? Should we at all go ahead and discuss about hormone replacement therapy? Let's see. Let's pick up the points. So, we do understand that menopause is the final cessation of periods, but women quite often have some changes even before this official menopause. So, what are the stages related to menopause, and would you at all consider HRT or a hormone replacement or hormone therapy, whatever you call it, even before menopause?
Thank
Dr.
you,
Mishra.
Dr. Chaudhary. As a matter of fact, there are two questions, like what are the stages and whether we should consider MHT, menopausal hormone therapy, before menopause. Now, I'd like to say in our literature, we do not use the term hormone replacement therapy because hormone replacement therapy is used for many other indications, as you have mentioned at the very beginning. We call it MHT or menopausal hormone therapy. Now, yes, as chronological age is an unreliable indicator for reproductive aging, we need to have some sort of staging for the purpose of clinical uses and for the purpose of research as well. And I'm proud to say that one of the gynecologists from India has first staged these ladies into 3 groups. And subsequently, of course, in 2001, a more comprehensive one, the straw classification came, which has some limitations, which has divided the ladies' life into 7 different phases. The 3 broad classifications were reproductive phase, then menopausal transition, and then postmenopausal phase. Here, the final menstrual point is the anchoring point. Then it has certain limitations, and because of those limitations, it was again updated by ASRM and a large number of organizations, and they sat together and came out with an updated version in 2011, where this is called a straw plus 10, and means that 3 broad classifications are already there. They are again subdivided into 10 different groups. Now, this classification...
Can we have the simplest classification for our physician colleagues?
It can be divided into 3 groups: reproductive group, early, peak, and late; then menopausal transition, early and late; then the postmenopausal one, again early and late.
So before menopause, how do we identify it's a menopausal transition?
The thing is that at this phase of time, the cycle becomes irregular, cycle becomes little long, and often delayed by a month, often some misses a period. And if you need to corroborate these findings with some surrogate markers, you can do that if the facility is there. Otherwise, at a particular age, these are the markers. Not that premature ovarian insufficiency cannot occur, but one needs to understand the age is an important denominator.
Right. Good. So even in this menopause transition, do we need to use HRT or MHT, let us say?
Yeah. Although the term is menopausal hormone therapy, and primarily means it for postmenopausal purpose, there are ladies during the phase of menopausal transition, as I said, there are wide hormonal fluctuations and the gradual loss of oocytes. There is altered responsiveness of gonadal steroid feedback that can lead to bothersome vasomotor symptoms, mood swings, cognitive dysfunction, temporary of course, and genitourinary changes and certain other things that probably can lead to some inferior quality of life. And the patient comes with that, still she's having period, and still the FSH level is not beyond the diagnostic parameter of menopause. In that case, one needs to take care of the patient by giving some sort of lifestyle intervention measures, maybe some medications as well, like low-dose oral contraceptive, maybe MHT, maybe some non-hormonal preparations, depending on the circumstances and individual characteristics.
Okay, thank you. So now we come to Dr. Arundhati Dasgupta. A very important issue is who should be the ones who should receive MHT, as Dr. Sukanta Mishra correctly possibly would like to term it.
Sir, while we acknowledge that, yes, indeed, menopause has so many positive sides to it, as Dr. Mishra just told us, we have to admit that it also brings along a lot of negative symptoms, particularly vasomotor symptoms. So ladies in the postmenopausal period, or even in the perimenopausal period, as Sir had just said, who have moderate to severe vasomotor symptoms, hot flushes, night sweats, that is affecting the quality of life for that person. That is one indication. The second indication would be GSM, or genitourinary syndrome of menopause, in which case the female is getting a lot of vaginal dryness, there's dyspareunia, there's burning, irritation, frequent urinary tract infection that cannot be explained otherwise. That is a second indication. A third would be for the prevention of osteoporosis. Women who are at a significant risk of osteoporosis and fracture when the other therapies are inappropriate. That is also considered to be one of the indications. Also, women, nowadays we see a lot of premature ovarian insufficiency. So women who are getting menopause before the age of 40. So at least till the natural age of menopause, they should be given MHT. There other relative indications would be like mood changes or mild cognitive dysfunctions, but this is, again, evidence is very mixed regarding these indications. But this has to be these symptoms in women who are less than 60 years of age, who have been in menopause for less than 10 years, and who do not have any contraindications for the use of MHT. Contraindications being breast cancer or uterine cancer or thromboembolism, or relative ones being migraine and hypertriglyceridemia. So we know the contraindications. Somebody who doesn't have contraindications, has these problems and falls in that age category would be the right person to be given the MHT.
So that's a clear message. So we now come to the wise one, Dr. Ganpati Bandwal. So Dr. Arundhati has started a lady because of her hot flushes and maybe genitourinary symptoms. So how long can we safely continue this treatment? Or how do we decide?
Well, the various societies, the Endocrine Society, all the societies say use the smallest possible dose for the shortest possible time for relieving the symptoms. But the thing is, why all this controversy happened, I think, after the WHI, people are all scared what to do. Then they came with a consensus that, okay, you can use it up to 5 years. But then they reviewed, there were a lot of other studies also. And now it is said that if you are immediately postmenopausal, you can actually use it till the symptoms subside, which could be 2 years, 3 years, 4 years, 5 years. Because the average duration of this vasomotor symptoms is around 7.5 years. And in some ethnic groups, it's up to 10 years. So if you started it with the menopause onset, you can actually continue it. And if you suppose that there could be a people who are having, the moment you stop, you taper it and stop it, they may get back the symptoms. Then what do? You can actually continue them. Now they are growing older also. Yes, so when you are growing older, you calculate the risk-benefit ratio. You can do an ASCVD risk score, see what's the risk, can we use these drugs, etc. So if you find they are low risk, you could actually continue to use for a longer time, say maybe even 60, 65 also. So you can actually use, of course, each year you have to counsel them, say, this is the problem, we'll calculate a risk. And then you could actually extend if they're getting back the symptoms once you stop the therapy. And in that cases, if they have been started on an oral dose, you could actually tell them, now I think is the time we go to more safer ones like a transdermal estrogen or with a micronized progesterone if they have a uterus. So we should individualize as the duration increase, whether they really require it. And if they continue to require it, you could go in for the better ones like the transdermal estrogen and the micronized progesterone.
So the clear message for our physician colleagues would be up to about 5 years if it's needed. Dr. Shukanto, is that what gynecologists also would agree? Or
Absolutely, absolutely. But as a matter of fact, yes, please.
No, I know specific gynecologists who suggest to continue up to 65 and whatever. But those are in specific instances.
There are no such guidelines, as Dr. Ganpati has highlighted. If it has been started around the time of menopause, the patient appreciates the risk and benefits, and otherwise healthy lady, it can continue until the, say, 5 years, more or less safely. And then, of course, it needs to be evaluated as she progresses in her age. the risk factors needs to be considered. Again, it should be a shared decision between the doctor and the clinician. The drugs and routes may need to be changed accordingly. But yes, there are only specific and rare situations. There is another group of women, that is those who are premature ovarian insufficiency group of women. For
Yeah.
that, it is a very difficult issue altogether, because the data says that average age of menopause in our country is 46. If that which is again changing. So if we consider 46 and the lady is diagnosed as premature ovarian insufficiency at the age of say 36 or 37, then the recommendation of the Indian Menopausal Society says you need to continue it up to the age of natural menopause, average age. But beyond that, whether you need to continue it or not, then again it becomes an issue of shared decision.
Right, sure. Okay. So, Dr. Bantwal has already referred to the Women's Health Initiative, or WHI, which actually led to significant practice changes in the use of HRT. I still remember my days when it was almost a disservice if you did not advise HRT to a menopausal lady. And today it's almost the opposite. And it was the WHI which sort of brought about this practice change. So I would ask Dr. Deep, so there are so many different facets of the WHI which we cannot go into in this short time span that we have got. But did you see any surprises from the results of the WHI?
Yes, sir. I think, as you rightly pointed out, sir, that initially there was all good things about HRT. Then we were in a fearful state. We were all afraid, all bad things about HRT. I think now we have reached a midpoint, a pragmatic use. I think now when we do a more nuanced study of the WHI study, told us that not all HRTs are same. When we talk of a estrogen and progesterone in combination pill, that works slightly different from a pure estrogen containing pill. And now we also know that WHI used only equine estrogen with medroxyprogesterone acetate. And as Dr. Bantwal just now told us, that now we have safer estrogens like transdermal, or maybe more estradiol valerate or micronized, so they are considered to be safer. So but then we still got some important messages. One key point which has been already highlighted in this forum is that when we give in the younger patients, say less than 60 years, 50 to 59 years was the arm, there the HRT was tolerated much better. The side effects were, the cardiovascular side effects were much lesser. And this trial also highlighted that the combination pill, it is the medroxyprogesterone acetate, which had a greater contribution to the increasing the burden of cardiovascular events. In fact, in younger women who received only estrogen pills because they already had hysterectomy for some other cause, there are a good number, nearly 11,000 women were only on estrogen pills. And in fact, in those young women who were less than 59 years of age, actually the occurrence of cardiovascular events did come down. And in compared to those women who were in more than 70 to 79 years of age, those who received only an estrogen pill, the occurrence of cardiovascular events drastically went up. Again, this found the basis of the safety of use of this class of therapy in the younger age group. And of course, it also, WHI trial covered different aspects: bone health aspect, the risk of breast cancer, overall the mood swings. So a lot of different things were covered. So I think that can be taken up subsequently.
Right. Yeah. So one of the issues for me, one of the surprises was that the estrogen progesterone arm was associated with more breast cancer than the estrogen only arm. So can I ask Dr. Girish Parmar, do you feel that progesterone causes breast cancer? Or as Dr. Deep Datta was referring to, it's just related to the medroxyprogesterone acetate, which we anyway use fairly commonly, at least endocrinologists do use it fairly commonly. So what are your views? Please unmute, Girish.
So if you look at data, I mean, the risk of breast cancer definitely was more with a combination arm than only the estradiol arm. So estrogen plus progesterone had a much higher chances of breast cancer. But then in that, it also depends on the duration of usage. And it was specifically in regards to medroxyprogesterone. So the type of progesterone used in the combination makes a difference. If you look at different types of progesterone, it is much lesser, probably neutral with bio-identical progesterone, like micronized progesterone. The risk is pretty less. Dydrogesterone, it is less. This combination of medroxyprogesterone with CEE, which was conventionally used at that point of time, did show an increase. So thereby showing that probably it's the MPA which probably was the result, was the causative factor. Again,
Okay.
when you're using it cyclically, the risk is pretty less compared to when you give it continuously. So it also depends on that.
Okay, fair enough. So we've heard a little bit about the progesterone. What about the estrogen? Dr. Arundhati, so which is your choice of estrogen for this group of women? Is it CEE or has it changed now?
So the data tells us that 17 beta estradiol is the best because it mimics the original estrogen the best, and also the side effects related to thromboembolism are much lesser. So while we've also, I mean, all of us continue to use CEE quite strongly, but I think the practice has shifted towards a wider usage of 17 beta estradiol. And now we have the availability of patches, which are available and which we can apply for about 1 or 2 patches a week. But the issue with the patches at times remains about in terms of humidity, sweating, and they peel off. At times, a part of it comes off, then you're concerned about the amount of dose that is going in. Those are issues that exist in our country, but nevertheless, we're still using patches, particularly in setups where, the person is working in an AC setup maybe, or is not likely to have a, peeling off of the patch. So in those cases, we prefer to use a patch these days, definitely. Oral usage of 17 beta estradiol is also pretty high in the dose of 1 to 2 milligram per day, and it's given daily. And topical use in terms of gel, sir, I've not used it, but I believe it's available and people are using it in our country, but I have not personally used it. Vaginally, have used both 17 beta estradiol and CEE, particularly for patients who have very prominent vaginal symptoms or dyspareunia or vaginal dryness. Regarding CEE, we are using it in a lower dose of 0.3 and not the conventional 0.625. And the synthetic CEE is also available. Apart from that, esterified estrogen is available, but I personally do not use it a lot, but it can be used. However, the side effect profile of ethinyl estradiol is a little higher as compared to 17 beta estradiol. So preferably, we stick to 17 beta estradiol or the CEE.
What about estradiol valerate? Do you at all use it?
Yes, sir. I do use estradiol valerate also. I do use.
Yeah. Right. So this was the endocrinologist perspective. What's the gynecologist perspective?
I completely agree with Dr. Dasgupta. In fact, she had mentioned all the valid points related to the type of estrogen and the thing that we use. Primarily, we prefer 17 beta estradiol, of course. And of course,
do you? Sorry to interrupt.
Oh, yes,
so
please.
do you use that as oral 17 beta estradiol?
Mostly.
Okay, right.
Mostly.
The bioavailability is not great, as I understand. Yeah. Okay. Right.
And
yes.
patches and gels are only selective, and patches has already highlighted the limitations and disadvantages of the patches. We use only in selective patients. Gels, yes, available nowadays in our country, but again, only in limited number of cases. Either we use CE or something tested. I don't prefer.
Okay. How does the cost compare? Roughly a month's cost.
I mean, patches and gels are quite expensive. So that
quite means 5 times more expensive?
It is around 5,000 rupees a month. And in contrast, If you go for CEE, which is about 500, I believe, 500, roughly 500, and 17 beta adult, a little around that figure.
Right.
So 5 to
Right.
10 times. So
Yeah.
that's an important denominator to decide which one you are going to use for a particular patient.
Right. So we come back to Dr. Ganpati. You also mentioned about different routes, Dr. Arundhati, Dr. Sukanta Mishra also. So does the route of administration matter?
Well, so for effective control of the vasomotor symptoms, etc., both are equally good, whether you use orally or whether you're using transdermally. But the side effect profile is actually lesser when you use a transdermal thing because they don't activate the hepatic enzymes. So they don't activate. So that's the reason, if at all you want to use transdermal, beneficial for side effect profile. So it has a lesser. So you take into the lipids. Lipids, if you see the oral ones increase HDL, increase triglycerides also, and reduce the LDL, whereas the transdermal can actually reduce the TG as well as the total cholesterol also, in addition to increasing it. So that's one of the good part of that. But the lowest doses are available of transdermal. That is actually not good because that does not effectively control the vasomotor symptoms. Otherwise, the usual doses are equally good. Then coming to if somebody has a sexual dysfunction in addition, then actually a vaginal route is actually better than oral or whatever for that matter. One of the reason is it does. I mean, even the transdermal will also be good because it should not stimulate the SHBG. Now, it actually these can reduce the SHBG. So if it reduces the SHBG,
Increase.
there's increased free testosterone, so that activity will be better. So that's another advantage. If you take cognition wise and all, it's all the same, whether you use oral or whether you're using a transdermal. Bone effects are also similar, whether you're using oral or for that matter, transdermal also. Side effects, yes, venous thromboembolism more with oral. It does happen with the transdermal, but slightly lesser, you can say. So side effect, that's how it actually matters.
Right.
If you take
So
oral versus vaginal preparation of progesterone, in that case, actually, the transdermal, you also have a transdermal preparation. They're not well absorbed, they say, erratic absorption. So in those cases, in that way, oral progesterone is actually better than transdermal types. Of course, micronized is better because of the lesser side effects.
right. So can I have a quick?
Can I say something? Can I say
Yes.
something?
Yes.
Yes. Yes.
At this point, we all were discussing about the route of administration of estrogen primarily. Dr. Ganpati had touched actually the route of administration of progesterone. Now, during the menopausal transition, when the patient had come with, say, irregular bleedings, and she doesn't have any endometrial pathology or any other uterine or ovarian pathology, in those situations, we have an option of using intrauterine progesterone, which serves a very important purpose. And there's low dose of progesterone, so progesterone side effects are minimized. It can be kept there inside the uterus for 5 years. It gives relief to the patient, and one can continue with the estrogen, the route which is acceptable to the patient or preferable to the patient. Besides that, progesterone gels are also, vaginal gels are there, but that again, it is primarily used for infertility patients, not for this menopausal hormone.
Right. We come back to Dr. Deep Datta, and this is about bone protection. So WHI very clearly showed that whether you're using estrogen alone or estrogen or progesterone, you definitely do good to the bone health. So should we routinely consider in postmenopausal women MHT for treatment of osteoporosis?
Yes, sir. The bone health data is pretty strong, but we must realize the estrogen effect on bone is primarily because of its inhibitory effect on osteoclasts. And this inhibitory effect is not permanent. When we stop giving the HRT, the estrogen is not there, the osteoclasts are reactivated, and the patient will lose the bone. The quantum
So
of bone.
which effect is permanent? Maybe bisphosphonates have a
Yes.
somewhat longer effect even after you stop, but others, not any of them gives you permanent effect.
Yes, sir, agree. Except for bisphosphonate, which stays in the bones for decades, nothing works permanently. But we must realize that we are using HRT only in the younger postmenopausal women, and we know that the risk of fractures progressively increase over the age. The very group of patients who would most need the HRT for bone health are the contraindicated groups where we would not be using, and hence it
Right,
has not caught up as a primary
right,
treatment for osteoporosis. Of course, we are going to give it for premature ovarian insufficiency, and the bone health are icing on the cake, but it's never the primary outcome.
right. Good. So, what about using HRT for prevention of diabetes, Dr. Girish? Because once again, data suggested there's less progression to diabetes in people who had this hormonal treatment.
Yeah, I think if you look at estrogen effects on insulin secretion, insulin action, in terms of the adipose tissue distribution, it has a quite protective effect, which is usually lost after menopause. But that doesn't mean, and that is not acceptable, and neither it is FDA approved to be used as a therapy for prevention of diabetes. So, as of today, we don't use this for prevention of diabetes. When you're using as MHT, the progesterone does blunt the beneficial effects of estrogen as a combination therapy. But to use this solely for prevention, it is not recommended.
Okay. Dr. Pragna, I would request you to put any questions from our audience in the chat box.
Sir, we have right now 1700 viewer, but we are waiting for the questions from the
Okay,
audience. So once they
okay,
will ask, I will put on to the chat
okay,
box.
okay. 1700. So that's almost
1700.
seems almost a record number. Okay, good. So, for diabetes prevention, no. So, as we all know that premenopausal women are protected sort of against the risk of atherosclerotic cardiovascular disease to an extent. What about using MHT for preventing coronary heart disease in postmenopausal women? We start early. We're not starting maybe at 60, but we start at 45 or 50. Dr. Deep Datta.
Yes, sir.
Sorry.
The thing is, we have to look at the whole picture. When we are talking of prevention of cardiovascular disease, um, uh, now we are talking primarily primary prevention at this age. We're not talking of primordial prevention or secondary prevention. So at this time, we have much better agents. Now we have very strong data to show that if we can keep the LDL cholesterol less than 70 milligrams per deciliter, that can have a good effect. So the use of statins have caught up, and the evidence is stronger in that regard. The beneficial impact on lipid profile is also much more marginal, and data is not strong enough to be used it as a primary indication for prevention of cardiovascular events. And we must realize that, sir, when you talk of cardiovascular events, we're not just talking of myocardial infarction, we're talking of stroke, we're talking of heart failure, we're talking of hospitalization for with heart failure. So I think if you look at the data is pretty heterogeneous. We look of cardiac events versus stroke events also, and the
Mhm.
thromboembolic event is a big red flag which really blunts out the overall picture.
So here quickly, can I ask you first, and then all the other faculty? I'll also chip in as to your experience of thromboembolism on HRT. Deep, how many have you seen?
Thankfully, I have never seen, But even if
Okay.
one patient would have thumb
Yeah,
embolism,
yeah.
it would be a big headache for me.
I do understand. Arundhati?
So I too have never seen, probably because my usage of MHT has been a little guarded. I have really not
Okay.
used it beyond the 55-year-old category. I've not started ever.
Okay.
So I've
Okay.
kept it limited.
I
So
have
probably
actually, yeah,
that is the
Yes,
reason.
yes,
I,
Ganpati.
I have seen actually 2, 3 patients, and in one, what happened was she told, sir, I get always the side effects. So I was actually relieved. I started her on this. Don't worry, sir, I get all the side effects of all the medications. Then what we did, we referred to her hemat, and we restarted her at a later date along with some amount of what do you call anticoagulation actually. So
Okay.
for that patient,
So, and you continued the
yes,
MHT.
right.
That was brave. Yeah.
I
Okay.
mean, the hematologist was involved.
Right. Okay. And Dr. Girish?
I haven't seen, sir.
No?
No.
And Dr.
Okay.
Shukanto, maybe they won't report to you. Maybe they will go to the physician.
Yes,
Yeah.
I have not encountered any such patient. Probably as Dr. Arundhati Dasgupta was mentioning, we take a lot of guard while prescribing HRT. We strictly follow the guideline. Never prescribed in a lady with a history of DVT or something like that, or the lady is predisposed to DVT. If at all she is required, in such situations, I think it is transdermal preparation would have been better.
Yeah.
That definitely reduces the possibility.
True.
So that's that. Besides that, of course, we have non-hormonal preparation to give her some relief to the condition.
Yes, Deep.
So I
Yes,
would
Deep.
just add that we are just lucky that we have not faced. However precautions we take, the person will have, and it's better in a litigious society always write in the prescription, stop if any symptom suggestive of DVT, and tell the patient.
Yeah, that's a good suggestion. I would also say that at least in my practice, I have not come across whether they didn't consult me or I didn't come to know about such an event. I can't say, but I haven't seen so far. Touch wood. Right. So one of the issues related to menopause, of course, is mood changes, and one of the expectations of MHT has been that it will improve cognition. It will even going further, maybe decrease the risk of dementia. So, can I ask Dr. Girish as to what are the effects of HRT or MHT on improving cognition?
So, as far as cognition is concerned, the effects are mixed. There are some studies which have shown that it benefits, especially if started early, perimenopausal or early postmenopausal, especially in younger women. And some have shown no real benefits, negative effects, especially older postmenopausal women. When you're looking at cognitive domains, probably verbal memory, processing speed, executive function, these things improve if started earlier. Another segment probably is those who are with ApoE4 carriers. Over there, it does help. But otherwise, some studies have been negative. So it's a mixed bag.
Right, possibly only on this indication, probably we wouldn't be
Yes,
pushing
won't. Definitely.
MHT. Right. So we have a question which is actually a quite broad. So whoever would like to take it is how to withdraw HRT. What are the consequences of HRT withdrawal? I don't have the doctor who has put the question, the name of the doctor. Recent studies show increase in gallbladder disease and dementia. Kindly give us your views. Does it increase gallbladder disease on withdrawal? Maybe I'm not aware. So, if anyone would like to comment on that,
Sir, can I take that?
yes.
So I think he's talking about the increase in gallbladder disease with the use of MHT, because withdrawal does not cause that.
Yeah,
But,
that's what. Yeah,
so it's basically the estrogenic component which makes the
yeah,
bite more lithogenic, and thereby the chances of
yeah.
getting cholelithiasis is more marked, and which is why that is also a relative contraindication while starting MHT. So I think, yes, there are studies telling us about an increase in gallbladder disease with the use of estrogen. That is there. Dementia, as I think Dr. Girish has mentioned, in the younger age group, it's the benefit. But in the older age group, there have been questions about the association with dementia. And it's been more with the combined group rather than the estrogen only group. So estrogen only has, in fact, seen benefits in terms of dementia, but the combined group in the age group of more than 65 did show, there were indications towards an increased incidence of dementia. So that concern has been there.
Right.
Can I say something?
Yes.
Can I say
Yes.
something?
Yes.
As regards to gallbladder disease, the information that we had was extrapolated from the use of ethynyl estradiol, which is being used very rampantly for in cases with oral contraceptive P. Now, this information somehow was extrapolated to the use of estrogen, which is being used in case of MHT. But these two are a bit different, considering the doses and the potency. And it is there only in the list of relative contraindications because we are trying to be as protective, as guarded as possible. But as such, there is no such literature which shows the increased propensity of gallbladder disease in cases of users for MHT. And regarding dementia and cognition, I think, yes, increasing it, there are literature suggesting that there is increased possibility.
Right. I would once again appeal to all our audience across the country. If you have any queries, please put them your questions so that we can ask our elite panel this evening before they decide to scoot off from us. So we continue our discussion. So breast cancer survivors, and we are on to Dr. Shukanto Mishra. And many of them have estrogen deprivation therapy. And we have seen HRT giving rise, being associated with increased risk of breast cancer. So what do we do for managing menopausal symptoms in breast cancer survivors who had estrogen deprivation treatment as part of the treatment for the breast cancer?
That's a very delicate issue, delicate question indeed. As a matter of fact, for breast cancer survivor, estrogen therapy is generally contraindicated. And if we look back into the evidences, there are several observational studies that suggest there is reduced risk of breast cancer. And not only that, there is, in fact, a reduced chance of mortality as well. In fact, meta-analysis of those observational studies also suggests this, but this may be due to selection bias of the patients. But if we look back into the randomized control trials, there are two RCTs addressing this particular question, and they have contrasting views. One study, hormone replacement therapy, is it safe? It suggests that there is increased risk of breast cancer among the breast cancer survivors. There's increased chance of recurrence. And the other study, the Stockholm breast cancer study, it suggests there is neutral effect or, in fact, reduced effect. But surprisingly, there is increased chance of breast cancer in the contralateral breast.
Yeah.
So that is surprising. So based on this, I think if the patient has got bothersome menopausal symptoms and she doesn't get adequate relief from the non-hormonal treatments, but then of course one might have to consider this, but it should be a tripartite meeting with the oncologist, with the patient, and the doctor, and the benefits and risks has to be clearly explained to the patient, and depending on that, one can prescribe with the lowest possible dose for the shortest period of time to have the maximum benefit. Now, coming to those patients who are receiving, tamoxifen.
Yeah.
For those patients, one has to be very careful because whenever we use non-hormonal preparations, Paroxetine as such is a very good drug as a non-hormonal preparation, escitalopram, etc. But these drugs are in fact block the tamoxifen to be converted to the active metabolite, and that's why these are not very preferred drug in cases of patients who receiving this tamoxifen for breast cancer survival. So one has to be careful in that aspect as well. Or of course, vaginal therapy, the same issues are there. So all in all, it has to be a tripartite meeting. It has to be a moderate to severe symptom, not responsive to non-alternative or other treatment.
Right. Good. So we are sort of trying to wind up our program this evening, and we come to Dr. Ganpati. So we are nowadays talking of bi-agonist, dual agonist, and tri-agonists in diabetes treatment. But we already had a tri-agonist in sort of MHT in tibolone, which acts on estrogen, progesterone, and androgen receptors. And I do remember that once the standard hormone replacement treatment came into sort of disrepute after the WHI, tibolone was being used quite a lot. So do you think this is better, or is it still to be preferred over standard estrogen or estrogen progesterone?
No. Yes, initially post the WHI trial, they were actually using it. They thought this is having the same effect like an MHT, but with a lesser side effect profile. But then recent reports say that there's an increased risk of recurrence of CA breast. That is number one. And there's an increased risk of VTEs, strokes. Actually, there was a study, it was a live study, where they found that there was a threefold increase in the risk of stroke. Of course, other studies didn't show that. That was another thing. So where does it have a place? Suppose somebody is having a decreased libido. That's one place perhaps it hacks because of its one of the delta 4 metabolite, which is highly androgenic. And also maybe post TAH BSO, that's a time because you're suddenly off the estrogens as well as the ovarian androgens also. It's suddenly come down. So that's another place perhaps where when the patient is having a symptom, we can actually use this drug. Otherwise, you have to be very careful. More than 60, increased risk of strokes, etc. And of course, don't use it in patients with CA breast.
Right. So Dr. Piyush has asked, how do we increase awareness about HRT use in India? I think it has to be through these programs, and then again, the individual physicians through discussion with their patients. It has to be discussed with their patients, the pros and the cons. HRT is supposed to be expensive. How to take it to masses? I don't think it's our job to take it to masses. It has, as we understood so far from all our panelists, that women who do have symptoms, probably the ones who should be prescribed, not routinely every menopausal woman at this point of time. I don't think we would be keen to have them on MHT. And so let's come to the final question of this evening. And let's have Dr. Arundhati Dasgupta first respond, and then maybe Dr. Sukanta Mishra. How to monitor a lady on HRT or MHT? What do we look at?
So routinely, sir, firstly, before starting, we need to take a look at certain parameters. We will be looking at the lipid profile, the metabolic status. And once you have initiated therapy, basically, there would be some aspects that you would be looking into that commonly also, again, the lipid status, the liver profile. That would be a concern if you're giving it the oral estrogens. Unless, however, the patients do not have symptoms, you do not need to regularly check. If you have put in the patient for primarily for osteoporosis, you would also be looking at the BMD and looking at, what has been the benefit with the use of the the MHT. That would
Do
be there.
do
Patient
do
is
do 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 we need a mammogram before starting on
definitely,
MHT?
definitely,
I mean,
definitely
oh
a
no, no. So
mammogram and a pap
it's
smear.
monitoring. Okay.
A mammogram and a pap smear. A mammogram is also something which needs to be done after 2 to 3 years,
Yeah.
particularly if the
Yeah.
patient has been on a combination therapy. That needs to be done. If the patient develops any abnormal vaginal bleeding, in that case, a uterine examination needs to be done, a pap smear needs to be done, and if required, an endometrial biopsy needs to be done.
Right.
So,
Dr. Dr. Shukanta Mishra.
As a matter
Anything?
of fact, MHT is a prolonged therapy, and for that we need to monitor the patient from time to time. Pre-therapy evaluation of the patient is extremely important. As a gynecologist, as Dr. Dasgupta was pointing out, all the tests. But nowadays we don't go for pap smear. If there is a facility, we go for directly HPV DNA test, which is more specific. Because pap smear has got a very poor specificity, we now know that. So we go for HPV DNA test, which gives more direct information to regarding cervical pathology. And this also gives us an opportunity to have the overall metabolic status of the patient for the first time. Maybe she is coming to us for the first time after so many, after childbirth. In between, she had never met a doctor, forget about a gynecologist. So that gives us an opportunity to weight, BMI, blood pressure, basic parameters, everything was taken into consideration. And then the patient was asked to come back after 3 years. And then we look into the fact when she had her final menstrual period. Because we know it's a retrospective diagnosis. So that is very important. When we start the medicine, depending on the type of therapy that we administer, I mean the formulations, if it is continuous type or sequential type, if it is close to menopause, then we go for sequential type. And if it is go beyond 1 year of menopause, then we go for continuous combined type. And if the patient continues to have persistent bleeding after 6 months of initiation of hormone therapy, of course, that needs to be evaluated the way we do it. And yes, initially you ask the patient to come back after 6 years. We need to know whether she is relieved from her symptoms that for which she has come primarily, and whether we have got an opportunity to reduce the dosage or not. And at the same time, each meeting subsequently gives us an opportunity to discuss the issues. And after that, we continue to do it a yearly basis. Then at one point of time, we need to consider when to stop this. So these are the issues that we need to discuss from time to time. So
Right.
monitoring is extremely important.
Right. So I did say this was the last question, but audience has the last word. So we have a question in the chat box. Dr. Kanta Rathore asked, we hear about receptor-specific therapies for tailored treatment. What are these? Any of the endocrinologists, brilliant endocrinologists, will like to discuss? In relation to MHT, let us say. I mean, something like giving you the good effects shown
Yeah,
of
you
the.
have the SERMs, no, selective estrogen receptor modulators. Like nowadays, what they're using is the bezodoxifene that can actually be used. In fact, you have a thing known as a TSEC, the tissue selective estrogen complex, actually can be used, which is bezodoxifene. Plus, you add CE also, the conjugated equine estrogen. So you get the benefits, lesser side effects, and more effects. Also, you can actually use this. So that's one thing. Then you have
Yeah,
one more is there. The ospemifene is
Ostomicin.
there. Yeah, that's
Ostomicin.
also there. It's similar to that. You're like the roloxifene. So, like roloxifene, the only thing is it has a good effect on the breast, etc. But then increased risk of see, we are using mainly for menopausal hot flushes. The hot flushes actually worsen when you actually use that drug.
even with, yeah,
Yeah, even with
Or,
osmifemicine also. So that's
or,
one drawback of that. But then increased risk of VTs are still there when you use this. So that's other thing to be kept in mind.
uh,
right?
Osmanthus is primarily we consider this for vulvovaginal atrophy, that is GSM, not for systemic use. Systemic purpose, I mean. And ESEC, I mean, bajedoxyfen, the combination of 3 milligram of bajedoxyfen.
So I can't hear you. Maybe we lost you.
Yes.
Yeah.
Am I audible
Once
now?
again, please. Yes.
Yes. Bajedoxyfen is not, I mean, the combination of CE plus bajedoxyfen 3 milligram is going to be available in our country very soon. I heard it, but I don't know whether it has come into the market or not. The beauty of this product is that you don't need to use progesterone. So the progesterone-related side effects will be the least that we have the benefit. But let it come, let it we have the clinical practice. The evidence out of that, I think, that is accrued will probably help us to form a better recommendation.
So thank you very much. So that was a wonderful evening of learning for all of us, I hope. And we know the pendulum has swung from this end to the other, and we are probably somewhere in the middle, as Deep or someone was mentioning. So it's no longer that you cannot use MHT. You do need to use in a number of women, and we should be using them. But of course, we are aware now of the potential adverse effects, and especially we do not use them several years after menopause. It should be soon after menopause and relatively younger age group women. And with these, we have also learned of the new developments that are coming in, which would possibly make it somewhat more acceptable, safer for more number of women. So with this, I would profusely like to thank all of our expert panelists this evening, Dr. Shukanta Mishra, Dr. Ganpati Bantwal, Dr. Arundhati Dasgupta, Dr. Deep Datta, Dr. Girish Parmar, and of course, all our physician colleagues across the country who have been keen participants in this program month after month. And of course, the INTAS team who takes all great care to bring us all together on this forum. So over to INTAS for the final words.
Thank you, Dr. Subhankar and our faculty members. We have a good insight about the hormone replacement therapy today, and we have also learned about some day-to-day questions in our life. Also, I want to thank you, our delegate team. More than 2,100 have joined us. So thank you so much, everyone. I also want to thank our field force who have worked effortlessly to join all these delegates, and we are always eager to support this type of educational activities. With this, I thank you everyone and wish you have a pleasant evening.
Thank you so much. Thank you so
Thank
much.
you, everyone.
Thank you, everyone.
Very good.
Thank you so
Very
much,
good
everyone.
night.
Thank you so much.
Elite
Bye-bye.
panel.
Yeah, thank you. Bye-bye. Good night.
Thank you.
Good night, sir.
Bye.
Good night.